Greetings my dear friend, my name is Maxim and welcome to my channel, and today we are going to be discussing antiarrhythmic drugs, namely the cardiac action potentials, dysarrhythmias, pathophysiology of cardiac arrhythmias, Wuhan-Williams classification, class 1 till 5. Well, without further ado, let's enjoy the lecture and dive into it. Dysarrhythmias are irregularities in the heartbeat, including when it is too fast or too slow. Signs and symptoms include palpitations, lightheadedness, passing out, shortness of breath, chest pain, may predispose a person to stroke or heart failure or even sudden death. Arrhythmias are often categorized into 4 groups. First one, extra beats. A premature heartbeat or extrasystole is a heart rhythm disease corresponding to a premature contraction of one of the chambers of the heart. 2 types. First one, premature atrial contraction. Second, premature ventricular contraction. Second group, supraventricular tachycardias. Supraventricular tachycardia is an umbrella term for fast heart rhythms arising from upper part of the heart. 4 types of SVT: atrial fibrillation, atrial flutter, paroxysmal supraventricular tachycardia, Wolff-Parkinson-White syndrome. Third group, ventricular arrhythmia, premature ventricular contraction, either bigiminy or trigiminy, accelerated idioventricular rhythm, monomorphic ventricular tachycardia, ventricular fibrillation, torsades de pointes, re-entry ventricular arrhythmia, and so on. Lastly, bradyarrhythmias, which is sinus bradycardia, is a slow resting heart rate, commonly under 60 beats per minute, and sick sinus syndrome. The cardiac action potential is a brief change in voltage membrane potential across the cell membrane of heart cells. This is caused by the movement of charged atoms, called ions, between the inside and outside of the cell, through ion channels. The cardiac action potential arises from a group of specialized cells known as pacemakers cells that have automatic action potential generation capability. Phase 4 of the action potential occurs when the cell is at rest, diastole. In the standard non-pacemaker cell, the voltage during this phase is more or less constant, minus 90 mV. The resting membrane potential results from the flux of ions into the cell, sodium and calcium. The flux of ions out of the cell, potassium, chloride and bicarb. Now I'm drawing a 5-phase action potential that we are going to sort out in the near future. But now, let's focus on phospholipid bilayer, which contains sodium-potassium ATPase, sodium-calcium pump and potassium channels. The resting membrane potential is mostly equal to potassium equilibrium potential. Pacemaker cells are never at rest. In these cells, phase 4 is also known as the pacemaker potential, during which the membrane potential slowly becomes more positive until it reaches minus 40 mV threshold potential. The pacemaker potential is thought to be due to a group of channels referred to as HCN channels. Hyperpolarization activated cyclic nucleotide gated. They allow the passage of both potassium and sodium into the cell. These channels open after a very negative voltage, after phase 3 of the previous action potential, due to their unusual property of activated by very negative membrane potentials they called funny current. Another hypothesis regarding the pacemaker potential is the calcium clock. Calcium is released from the sarcoplasmic reticulum within the cell. This calcium increase stimulates Sodium-calcium exchange. Imagine a cell with beta-1 adrenergic receptor that's bound to G-stimulatory protein. This protein activates adenylate cyclase, which in turn transforms ATP into cyclic AMP and eventual protein kinase A activation. Protein kinase A phosphorylates sodium and calcium channels, as well as phospholamban protein, which inhibits calcium current in sarcoplasmic reticulum, thereby increasing the concentration of calcium in the cell. Phase 0. Rapid positive charge in voltage across the cell membrane, depolarization, due to a net flow of positive charge into the cell. In pacemaker cells, the increase in membrane voltage is mainly due to L-type calcium channels. The L-type calcium channels are activated more slowly than the sodium channels. Therefore, the depolarization slope in the pacemaker action potential waveform is less steep. Phase 1 begins with the rapid inactivation of sodium channels by the inner gate, inactivation gate, reducing the movement of sodium into the cell. At the same time, potassium channels, called ETO1, open and close rapidly, allowing for a brief flow of potassium out of the cell, making the membrane potential slightly more negative, a notch. There is no obvious phase 1 present in pacemakers. Phase 2, also known as plateau phase, due to the membrane potential remaining almost constant as the membrane slowly begins to repolarize. During this phase, delayed rectified potassium channels allow potassium to leave the cell, while L-type calcium channels allow the movement of calcium ions into the cell. These calcium ions bind to and open more calcium channels, allowing ryanodine receptors located on the sarcoplasmic reticulum within the cell, the flow of calcium out of the sarcoplasmic reticulum. These calcium ions are responsible for the contraction of the heart. Calcium also activates chloride channels called ETO2, which allowed chloride to enter the cell. This phase is responsible for the large duration of the action potential and is important in preventing irregular heartbeat, cardiac arrhythmia. There is no plateau phase in pacemaker action potential. Phase 3. The rapid repolarization phase of the action potential. The L-type calcium channels close, while the slow delayed rectified potassium channels remain open. This ensures a net outward positive current corresponding to a negative charge in membrane potential. This net outward causes the cell to repolarize. Cardiac cells have two refractory periods. First, from the beginning of phase 0 until partway through phase 3, absolute refractory period, which it is impossible for the cell to produce another action potential. This immediately follows until the end of phase 3 by relative refractory period, during which stronger than usual stimulus is required to produce another action potential. These two refractory periods are caused by changes in the states of sodium and potassium channels. During phase 0, depolarization causes the membrane potential to approach sodium equilibrium potential, the membrane potential at which sodium is no longer drawn into or out of the cell. As the membrane potential becomes more positive, the sodium channels then close and lock. This is known as the inactivated state. During this state, the channels cannot be opened regardless of the strength of the stimulus. This gives rise to the absolute refractory period. The relative refractory period is due to the leaking of potassium ions, which makes the membrane potential more negative, hyperpolarized. This resets the sodium channels, opening the inactivating gate, but still leaving the channel closed. And now let's discuss pathophysiology of cardiac arrhythmias. Altered impulse formation via increased automaticity is seen in increased SA node automaticity as well as increased automaticity of latent pacemakers. If the AV node and Purkinje fibers intrinsically depolarize faster than SA node ectopic beats, they will control impulse formation ectopic rhythm. Example: AV junction tachycardia. Abnormal automaticity is ectopic pacemakers in atrial and or ventricular myocytes. If non-conducting heart cells depolarize faster than SA node, they produce an abnormal ectopic rhythm, usually due to myocyte injury. Triggered activity. R-on-T phenomenon. After depolarization cause extraventricular contractions during the repolarization. Early after depolarization in long QT patients. Torsades de pointes. Delayed after depolarization in increased calcium patients. Idiopathic ventricular tachycardia. Altered impulse conduction. Re-entry loops. An impulse travels continuously around a circular path in the myocardium, continuously depolarizing that cardiac region. First one, unidirectional block. Second one, slow retrograde conduction. Conduction block. Delayed propagation of impulse due to electrically unexcitable tissue from ischemia, fibrosis, inflammation, or drugs. Decreased SA node automaticity, sinus bradycardia. If SA node rate decrease enough, AV node and Purkinje fibers initiate impulses called escape beats. A series of escape beats named escaped rhythm. You can remember cardiac tissue conduction velocity with this simple mnemonic party at Vegas Avenue, which stands for Purkinje, atrial muscles, ventricular muscles, and AV node, from fastest to slowest. And now I would like to take an opportunity and discuss a high-yield topic with you: supraventricular tachycardias. First one, atrial fibrillation, is an abnormal heart rhythm characterized by rapid and irregular beating of the atrial chambers of the heart. It often begins as short periods of abnormal beating which become longer or continuous over time. It may also start as other form of arrhythmia, such as atrial flutter, that then transform into atrial fibrillation. Signs and symptoms include palpitations, lightheadedness, shortness of breath, chest pain, increased risk of heart failure, dementia, and stroke. Risk factors include increased blood pressure, valvular heart disease, heart failure, coronary artery disease, cardiomyopathy, congenital heart diseases, including rheumatic fever. Or lung-related risk factors include COPD, obesity, sleep apnea, increased alcohol intake, tobacco smoking, diabetes mellitus, thyrotoxicosis. Diagnosis: ACG, irregular SPED QRS complexes without P waves. In order to remember causes of new onset atrial fibrillation, use the following mnemonic: the atrial FIPS, which stands for thyroid, hypothermia, embolism, alcohol, trauma, recent surgery, ischemia, atrial enlargement, lung or idiopathic, fever, anemia, high output, infarct, bad valves, stimulants. Atrial fibrillation treatment, A, B, C, D, E, which stands for A. Anticoagulants, B. Beta blockers, C. Calcium channel blockers, D. Digoxin, E. Electrocardioversion. Pharmaceutical medicines used for arrhythmias. For tachyarrhythmias and extrasystoles, use antiarrhythmics class 1 till 4, cardioglycosides, adenosine, ivabrazine, magnesium sulfate, and potassium medicis. For bradyarrhythmia and blockades, use M-chalina blockers and beta-adrenomimetics. Vaughan-Williams classification. Class 1. Agents interfere with the sodium channels. Class 2. Antisympathetics, beta blockers. Class 3. Agents affect potassium efflux. Class 4. Agents affect calcium channels. Class 5. Agent work by other or unknown mechanisms. Use this silly sentence to remember agents and their classes. Police department questions liquored man for peeing after drinking scotch in dark, dirty vehicle. Class 1A. Police department questions, which stands for procainamide, disopyramide, and quinidine. Liquored man stands for lidocaine and mexalidine. For peeing, flecainide, propafenone. Class 2 can be remembered 2 equals BB, beta blockers. Class 3, after drinking scotch in dark, amiodarone, dronidarone, satalol, ibutilide, dofitilide. And dirty vehicle, deltiazem and verapamil. Class 1A antiarrhythmics, mechanism of action. Inhibition of sodium channels, thus increasing phase 0, decreasing conductivity and widening QRS complex. Increasing phase 4, thus decreasing automatism. Inhibition of potassium channels, increasing phase 3, increasing QT interval. Important points: impact on SA and AV nodes. Increase the refractory period, decrease node pulse frequency, decrease AV conductivity. Class 1A antiarrhythmics increase phase 0, 3 and 4. On ECG you will see widening QRS complex and increasing QT interval. Use them in supraventricular and ventricular arrhythmias. On this diagram, I am representing blocked sodium channel and open sodium channel. Important points. Channel recovery from the block occurs at an average speed. For class 1A is more than 1 second. For class 1B less than 1 second, and for class 1C is more than 10 seconds. What does it mean? Not all sodium channels are released from the drug during the diastolic interval. Thus, the block accumulates, which leads to a decrease in conductivity and expansion of the complex QRS. The drugs in this class can be remembered with this visual mnemonic, where queen proclaims pyramid, which stands for quinidine, procainamide and disopyramide. All three of them inhibit muscarinic cholinergic receptors, thus increasing automaticity and conductivity. But quinidine inhibits alpha-adrenergic receptors, whereas procainamide inhibits nicotinic cholinergic receptors, leading to vasodilation, decreasing in total peripheral resistance, and tachycardia. Class 1A antiarrhythmics can reduce the strength of heart contractions via inhibition of sodium channels, thereby putting the calcium-sodium pump in direct position when calcium is thrown out of the cell in exchange for sodium. Side effects include decreased strength of heart contractions, decreased AV conduction, arrhythmogenic effect torsades de pointes. Quinidine can cause low blood pressure, decrease platelet count, and synchronism, which is tinnitus and headache. Procainamide can cause drug-induced lupus, and disopyramide heart failure. Class 1B inhibits sodium channels, increasing phase 0. Decreases effective refractory period by blocking late sodium flow in phase 2, increasing phase 4. On ACG may be a little decrease in QT interval. Use in ventricular arrhythmias, acute period of myocardial infarction, lidocaine, overdose of cardiac glycosides, phenytoin. The block does not accumulate. The impact on the QRS complex is minor. You can imagine our Mexican friend who enjoys eating taco and holding a lighter in his hand. This visual mnemonic stands for our Mexican friend Mexilatin, taco, tacoinamide, and the lighter, lidocaine. Important points: myocardial infarction, overload of cardiomyocyte with calcium, delayed after depolarization. Lidocaine blocks sodium channels. Thus, the overall concentration of sodium inside the cell decreases, which leads to throwing outside the cell of calcium and bringing free sodium inside the cell. Due to ATP deficiency in ischemic conditions, the ATPase function is disrupted. A large number of sodium channels are in refractory state. They are released from lidocaine slowly, and the block accumulates, which leads to a decrease in conductivity in the ischemic area. Class 1B side effects: lidocaine, hypotension, arrhythmogenic effect, decreased strength of heart contractions, CNS effect, tremor, seizures, drowsiness, altered mental status, paresthesia, hearing impairment. Phenytoin, arrhythmogenic effect, hypotension, cerebellar atrophy, osteomalacia, hirsutism, megaloblastic anemia, hypertrophic gingivitis. Class 1C antiarrhythmics. Can I have more fries, please? Which stands for moritizine, flecainide, and propafenone. They inhibit sodium channels, thus increasing phase 0, increasing QRS complex, increasing phase 4, decreasing automatism. Inhibit potassium channels, no effect on phase 3. Inhibit ryanodine receptors, impaired calcium release. On ACG, increase in PQ interval and QRS complex, use in supraventricular and ventricular arrhythmias. Side effects include arrhythmogenic effect, decrease the strength of heart contractions, metallic taste in the mouth, propafenone, contraindicated in structural and ischemic heart diseases, especially post-myocardial infarction. Beta-adrenergic receptors are coupled with G-stimulatory proteins, which activate adenylate cyclase, which in turn converts ATP into cyclic AMP, leading to eventual protein kinase A activation. Protein kinase A activates phospholamban, which inhibits sarcoprotein on sarcoplasmic reticulum. Also, protein kinase A activates HCN and L-type calcium channel, leading to overall increase in calcium concentration inside the cell. Blockade of beta adrenoreceptors leading to a reduction of current through HCN channels, thus decreasing AV automatism and decreasing SA node automatism, increasing phase 4. An increase in expression of HCN channels in typical cardiomyocytes may cause ectopic activity, decreasing calcium current through L-type calcium channels. Decrease automatism, SA node, increase in phase 4, decrease in AV conduction, increase in phase 0, and decrease overload of cardiomyocyte with calcium. On ACG, we can see increase in PQ interval, use in supraventricular and ventricular arrhythmias. Important points: anti-anginal effect, reduction of myocardial oxygen demand, redistribution of coronary blood flow in favor of ischemic areas. Antioxidant effect, carvedilol. Side effects of beta blockers include cardiovascular depression, bradycardia AV block due to beta-1 receptor blockade of the heart, bronchospasm due to beta-2 receptor blockade at bronchioles, may lead to acute exacerbation of COPD and asthma, unopposed alpha agonism, severe vasoconstriction, coronary arteries, hypertension, synenphylochromocytoma, or cocaine toxicity, may worsen vasospasm, Prince metal angina, depression, sleep disturbance, lipophilic beta blockers, withdrawal syndrome, short-acting beta blockers. Class 3, amiodarone, inhibits potassium channels, increasing phase 3 ERP and QT interval. Inhibits sodium channels, increase phase 0 QRS and phase 4. Inhibits calcium channels, decrease automatism and conduction. Inhibition of beta adrenoreceptors, decrease SA node automatism and AV conduction. Anti-anginal effects also seen. Use in supraventricular and ventricular arrhythmias. Side effects include bradycardia, decreased AV conduction, arrhythmogenic effect, photosensitization of skin, blue-gray hyperpigmentation, deposition of lipofuscin in the cornea, thyroid dysfunction. In healthy individuals, it transiently inhibits the synthesis of thyroid hormones. In regions with iodide deficiency, the risk of hyperthyroidism is higher. Peripheral neuropathies and myopathies, increase LC and AST, fibrosis of the lungs, direct toxic effect and immune damage, accumulates in the heart, lungs, liver, and the skin. Class 3, dronidarone, a structural analog of amiodarone that is devoid of iodine, inhibits potassium, sodium, calcium channels and beta adrenergic receptors, does not have a pronounced effect on thyroid function. Half-life is 24 hours, less than amiodarone. Class 3, vernaculant, inhibits atrial potassium channels, thereby prolonging repolarization. It differs from typical class 3 agents by blocking a certain type of potassium channels, the cardiac transient outward potassium current, with increasing potency as the heart rate increases. This means that it is more effective at high heart rates, while other class 3 agents tend to lose effectiveness under these circumstances. It also slightly blocks the HERG potassium channels, leading to a prolonged QT interval. The drug also blocks atrial sodium channels. The drug is used for treatment of atrial fibrillation. Side effects include dysgeusia, taste disturbance, sneezing, paresthesia, decreased blood pressure, and nausea. Class 3 Sotalol. The racemate consists of D and L-sotalol. L-sotalol non-selectively blocks beta-adrenin receptors. D and L-sotalol have the class 3 property. Beta-blocking effect is maximal in doses less than those needed to increase the duration of the action potential. Inhibition of potassium channels. Decrease automatism in SA node, decrease AV node conduction, decrease myocardial contractility, increase atrial and ventricular repolarization time, increase ERP. Treatment: atrial flutter, fibrillation, ventricular tachycardia. Side effects include torsades de pointes. Class 3 Nifedil inhibits potassium channels, thus increasing refractory periods of the atria, ventricles, and Gis-Purkinje system. However, the effect on atrial resting potential is significantly higher. Inhibits calcium and sodium channels. Anticholinergic effect include a relief of atrial fibrillation, flutter. Side effects: sinus bradycardia, increase QT, arrhythmogenic effect, increase ALT and AST. Class 4 Verapamil and diltiazem. Both inhibit calcium channels, L-type, thus decreasing SA node automatism and AV conduction. On ACG, prolonged PQ interval, use in supraventricular arrhythmias. Side effects: constipation, hyperprolactinemia, may decrease CNS dopamine signaling, bradycardia, AV block, gingival hyperplasia, verapamil, flushing, and edema. Digitalis, also known as the cardioglycoside. Mechanism of action: inhibits sodium-potassium ATPase. Reversible block of sodium-potassium ATPase leads to increase intracellular sodium. Increased sodium stimulates sodium-calcium exchange, thus increase calcium influx. Increased cardiac contractility. Increase vagal tone, cranial nerve number 10, slows conduction at SA and AV node, decreases heart rate. Clinical use: heart failure, atrial fibrillation. Side effects: narrow therapeutic window, toxicity is common, especially in hypokalemia, hypovolemia, renal failure, visual disturbances, yellow halos around objects, AV block, hyperkalemia, reversal, anti-digoxin, FAP fragments. Adenosine. The half-life is less than 10 seconds. Inhibits calcium channels, L-type, in SA and AV node. Stimulates potassium influx in cardiomyocytes and accept pacemakers and stabilization of RP. Imagine the cell with beta-1 adrenergic receptors, as we discussed earlier. Adenosine stimulates A1 receptor, which coupled with G inhibitory protein, which consists of alpha, beta, and gamma subunits. Alpha subunit inhibit adenylate cyclase, where beta and gamma stimulate potassium channels. Use adenosine in paroxysmal supraventricular tachycardia. Important points: vasodilator of coronary vessels, can cause coronary steal syndrome. Side effects include burning chest pain secondary to bronchospasm, sense of impending doom, flushing, hypotension, AV block. Lastly, magnesium sulfate. Magnesium is a physiologic antagonist of calcium and is able to displace it from the binded sites, disrupting the calcium current, decreasing heart rate and AV conduction. Magnesium is a cofactor in sodium-potassium ATPase. Decrease the toxicity effect of cardiac glycosides. Clinical use: preeclampsia, eclampsia, torsades de pointes, digoxin toxicity, arrhythmia with potassium and magnesium deficiency, side effects, hot flashes, hypertension, hypermagnesemia. Well folks, this is all what I have for you today. Thank you for watching. If you found this video helpful, please leave a like, comment down in the comment section and subscribe to my channel. I wish you a very lovely day and see you guys later. Goodbye.